Hello, my name is Hannah Rosenblum, and I am an Epidemic Intelligence Officer in the Division of Viral Diseases at the Centers for Disease Control and Prevention. Together with Patricia Wody, a public health physician in the Immunization Services Division, we will be presenting You Are the Key to HPV Cancer Prevention. CDC, our planners, our content experts, and their spouses' partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Content will not include any discussion of the unlabeled use of a product or product under investigational use. CDC does not accept commercial support for this continuing education activity. After viewing this presentation, you should be able to 1. Describe the burden of HPV infection and disease in the United States. 2. Define the importance of HPV vaccination in cancer prevention. 3. Describe recommendations for HPV vaccination of adolescents and adults. 4. Describe the rationale for routine HPV vaccination at age 11 or 12 years. 5. List 2 components of an effective HPV vaccine recommendation. 6. Identify relevant and compelling information to share with parents about HPV vaccine to help inform their decision to vaccinate their child. 7. Locate current immunization resources to increase knowledge of the team's role in program implementation for improved team performance. 8. Implement disease detection and prevention healthcare services to prevent health problems and maintain health. The first section will focus on HPV infection and disease prevalence. Human papillomaviruses, HPV, are a very common family of viruses that infect epithelial tissue. HPV types differ in their tendency to infect cutaneous and mucosal or genital epithelium. More than 150 HPV types have been identified, including approximately 40 that infect the genital area. Genital HPV types are categorized according to their epidemiologic association with cervical cancer. High-risk types, such as types 16 and 18, can cause low-grade cervical cell abnormalities, high-grade cervical cell abnormalities that are precursors to cancer, and cancers. In addition to cervical cancer, HPV can also cause cancers of the vulva, vagina, penis, and anus, as well as cancer of the oropharynx. Low-risk types, like 6 and 11, can cause benign or low-grade cervical cell changes, genital warts, and juvenile onset recurrent respiratory papillomatosis. Most people will be infected with at least one type of HPV at some point in their lives. An estimated 42 million Americans are currently infected with HPV, and 13 million new infections occur in the United States each year. Most HPV infections are acquired during the teen and college-aged years. The first HPV infection usually occurs soon after sexual debut. Most people will never know they have been infected. Women might find out they are infected because of an abnormal pap test with a positive HPV test or a diagnosis of genital warts. Men might also find out because of a genital wart diagnosis. This slide shows the number of cancers associated and attributable to HPV per year in the United States from 2014 to 2018. An HPV-associated cancer is a specific cellular type of cancer that is diagnosed in a part of the body where HPV is often found. An HPV-attributable cancer is a cancer probably caused by HPV. The numbers in the column, number of HPV-associated cancers, is obtained from cancer registries. The numbers in the column, percentage probably caused by any HPV type, come from a CDC population-based genotype study published in 2016. HPV causes nearly all cervical cancers and many cancers of the vagina, vulva, penis, anus, including rectal squamous cell carcinoma and oropharynx. CDC estimated that from 2014 to 2018, there were about 46,000 HPV-associated cancers in the United States each year. Based on the CDC genotyping study, about 79% of these cancers were probably caused by HPV. Most HPV-associated and HPV-attributable cancers in women were cervical cancers, while in men, most were oropharyngeal cancers. This graph shows the number of HPV-associated cancer cases that were diagnosed and reported each year in the United States from 2014 to 2018 by sex, cancer type, and HPV type. This is the most recent 5-year period with available data. The number of HPV-associated cancer cases is obtained from cancer registries and includes all carcinomas of the cervix and squamous cell carcinomas of the vagina, vulva, penis, anus, and oropharynx. As mentioned, the numbers attributed to specific HPV types are estimated from a CDC population-based genotype study published in 2016. On this slide, HPV types are grouped and represented as different color bars. The darker blue bar represents HPV 16 and 18, the types that cause most HPV-associated cancers and are targeted by all HPV vaccines. The teal bar represents other high-risk types that are targeted by the 9-valent vaccine currently being used in the United States, which we will discuss later, and grouped as 31, 33, 45, 52, 58. The lightest blue bar represents other HPV types. This graph shows the incidence rate of all HPV-associated cancers, all carcinomas of the cervix and squamous cell carcinomas of the vagina, vulva, penis, anus, and oropharynx by sex, race, and ethnicity from 2014 to 2018. Incidence rate means how many people out of a given number get the disease each year. Incidence rates of HPV-associated cancers varied by sex and race or ethnic group. The rates for women are shown in the solid darker bars, and the rates for men are shown in the lighter shade bars. In each race or ethnic group, women had higher rates than men. Those identifying as non-Hispanic had higher rates than those identifying as Hispanic. Among women and men, those identifying as white had the highest rates, and those identifying as Asian Pacific Islander had the lower rates. In the next few slides, I will show rates for the individual HPV-associated cancers, and you will note that differences by race, ethnicity vary by cancer. This figure shows HPV-associated anal cancer rates by sex, race, and ethnicity for the same period. It is estimated that about 4,900 cases of HPV-associated anal cancers, including rectal squamous cell carcinoma, were diagnosed in women and about 2,400 in men each year in the United States. Rates of HPV-associated anal cancer were higher in women than in men overall and in each racial and ethnic group, except for among Black women who had similar rates as Black men. White women had higher rates than women of other races. Black men had higher rates than men of other races. Some cancers of the oropharynx, which includes the back of the throat, including the base of the tongue and the tonsils, have been linked with HPV. In the United States, it is estimated that about 3,500 cases of HPV-associated oropharyngeal cancers were diagnosed in women, and about 17,700 were diagnosed in men each year from 2014 to 2018. These numbers are based on cancers in specific areas of the oropharynx and do not include cancers in all areas of the head and neck or oral cavity. Men had higher rates of HPV-associated oropharyngeal cancer than women. White men and women had higher rates of HPV-associated oropharyngeal cancers compared with other racial groups, and non-Hispanic men and women had higher rates of HPV-associated oropharyngeal cancers compared with Hispanic men and women. Vulvar cancers are rare. It is estimated that about 4,200 cases of HPV-associated vulvar cancer were diagnosed in the United States each year from 2014 to 2018. Women identifying as white had higher rates of HPV-associated vulvar cancer than women of other races. This graph shows the incidence of HPV-associated cervical cancers by race and ethnicity. It is estimated that about 12,200 cases of HPV-associated cervical cancer were diagnosed in the United States each year from 2014 to 2018. Women identifying as Black or Hispanic had higher rates of HPV-associated cervical cancer than women of other races or ethnicities. This may be possibly because of decreased access to Pap testing or follow-up treatment. Worldwide, cervical cancer is the most common HPV-associated cancer among women, with over 500,000 new cases diagnosed per year. Cervical cancer is the fourth most common cancer overall among women, and in some countries, it is the most common cancer. In the United States, cervical cancer was once the leading cause of cancer death for women. Now, it is the most preventable of all the female cancers. In the past 50 years, the Pap test has helped decrease the number of women in the United States diagnosed with cervical cancer by about 75%. However, even with an excellent cervical cancer screening program in the United States, there are still about 12,000 new cases of cervical cancer and 4,000 deaths each year. We can do better. No women should die of cervical cancer. Half of cervical cancer cases in the United States occur in women younger than 50 years, with 1 in 4 cervical cancer cases among women aged 25 to 39 years, during prime reproductive years. A cervical cancer diagnosis and treatment can be devastating to women and their families for a variety of reasons, including negative effects on their health, welfare, finances, and ability to work. Cervical cancer is treated at minimum with the removal of the cervix, but can also include radical hysterectomy, radiation, and chemotherapy. When some people talk about HPV disease, the focus is on the 12,000 cases of cervical cancer and the 4,000 deaths. In addition, each year, 1.4 million women will be diagnosed with low-grade cervical dysplasia. Each of these women with an abnormal Pap test will have a colposcopy and biopsy done, and then must wait to find out whether or not they have cancer. Also each year, more than 196,000 women in the United States are diagnosed with high-grade cervical dysplasia or cervical precancer. After receiving that diagnosis, many will go on to have a LEEP procedure or a cold knife cone biopsy of the cervix, which is shown in the image. Preventing cervical cancer is better than treating it. Preventing the infections that can lead to cervical cancer is even better.
This next section will focus on HPV vaccine recommendations. All available HPV vaccines are prophylactic vaccines that prevent HPV infection. These vaccines are made from virus-like particles and do not contain any viral DNA. Therefore, they are non-infectious and cannot cause actual disease or cancer. HPV vaccines produce a better immune response than an HPV infection. This chart demonstrates the HPV type targeted by 3 different HPV vaccines. Bivalent HPV vaccine targets 2 types of HPV. Quadrivalent HPV vaccine targets 4 types of HPV. And 9-valent HPV vaccine targets 9 types of HPV. Bivalent, quadrivalent, and 9-valent HPV vaccines all protect against HPV 16 and 18, the HPV types that cause about 73% of cervical cancers probably caused by HPV, and an even higher percentage of other HPV attributable cancers in the United States. Overall, 81% of HPV attributable cancers are estimated to be due to HPV 16 and 18. Quadrivalent and 9-valent HPV vaccines also protect against HPV 6 and 11, HPV types that cause anogenital warts. In addition, 9-valent HPV vaccines target additional cancer-causing types, which account for another 11% of all HPV attributable cancers. The additional 5 types in 9-valent HPV vaccine account for a higher proportion of HPV-associated cancers in women compared with men. All 3 vaccines are licensed in the United States. However, after the end of 2016, only 9-valent HPV vaccine has been marketed in this country. HPV vaccination is routinely recommended for adolescents at age 11 or 12 years The series can be started at age 9 years. For children starting the vaccination series before their 15th birthday, the recommended schedule is 2 doses of HPV vaccine. The second dose should be given 6 to 12 months after the first dose. CDC also recommends HPV vaccination for everyone through age 26 years if not adequately vaccinated. Vaccination is not recommended for everyone older than age 26 years. However, some adults ages 27 through 45 years who were not adequately vaccinated when they were younger may decide to get the HPV vaccine based on discussion with their clinician. HPV vaccination for people in this age range provides less benefit as more have already been exposed to HPV. The recommendations for HPV vaccine dosing schedules are: for persons starting vaccination before the 15th birthday, the recommended vaccination schedule is 2 doses of HPV vaccine. The second dose should be administered 6 to 12 months after the first dose for a 6 to 12 month schedule. For persons initiating vaccination on or after the 15th birthday, the recommendation is for a 3-dose schedule. The second dose should be administered 1 to 2 months after the first dose, and the third dose should be administered 6 months after the first dose for a 1 to 2 6-month schedule. This 3-dose schedule is also recommended for persons with immunocompromising conditions initiating vaccination at age 9 through 26 years. 9-valent HPV vaccine may be used to continue or complete a vaccination series started with quadrivalent or bivalent HPV vaccine. Persons are considered adequately vaccinated if they have completed a recommended schedule with 9-valent, quadrivalent, or bivalent HPV vaccine. No additional dose is recommended when any HPV vaccine series has been completed using the recommended dosing interval. HPV vaccines should be administered via intramuscular injection using a 1 to 1.5 inch 22 to 25 gauge needle. The preferred site is the deltoid muscle in the upper arm. A single dose vial is for one patient only. HPV vaccines can be administered during the same clinic visit as other indicated vaccines. Always follow a septic technique when preparing and administering vaccines. A new needle and syringe should be used for each injection. An adhesive bandage may be applied to the site if bleeding occurs. Before administering any vaccine, including HPV vaccine, healthcare providers should review the contraindications and precautions for the vaccine type. Anyone who has had a life-threatening allergic reaction to a previous dose of HPV vaccine or to a vaccine component, including yeast, should not be vaccinated. HPV vaccination is not recommended for women who are known to be pregnant. Wait until after pregnancy to vaccinate. However, pregnancy testing is not needed before vaccination, and no intervention is required if HPV vaccine is inadvertently administered during pregnancy. Similar to other vaccines, HPV vaccination may be delayed in persons with moderate or severe acute illness with or without fever. HPV vaccine should be stored in the refrigerator between 2 to 8 degrees Celsius, which is equivalent to 36 to 46 degrees Fahrenheit. Store the HPV vaccine in the original packaging in a clearly labeled bin in the storage unit. On this slide is a link to the HPV storage unit label that can be used to identify the HPV vaccine in the storage unit. This next section will focus on HPV vaccine safety. CDC monitors the safety of vaccines after they have been approved by FDA through the three systems shown in this table. First, the Vaccine Adverse Events Reporting System, or VAERS, is a spontaneous reporting system that serves as an early warning system to detect possible safety problems that might be related to vaccination. Anyone can submit a report to VAERS. VAERS accepts all reports from everyone regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. If a potential safety concern is identified from analyzing VAERS data, further studies are done in more robust data systems to confirm the safety concern. However, it is generally not possible to determine from VAERS data if a vaccine caused an adverse event. Second, the Vaccine Safety Data Link, or VSD, is a collaborative project between CDC and 9 integrated healthcare systems that monitors the safety of vaccines and conducts rigorous vaccine safety assessments. VSD data can be used to assess any potential causation between a vaccine and an adverse event. Third, the Clinical Immunization Safety Assessment Project, or CISA, conducts vaccine safety clinical research and assesses complex clinical adverse events following vaccination. Following FDA approval, HPV vaccines have been monitored extensively in VAERS, VSD, and by the manufacturer through post-marketing requirements as shown on the slide. We now have more than 15 years of HPV vaccine safety data from the United States. With more than 135 million doses of HPV vaccines distributed in the United States, the safety profile for HPV vaccines is well established, and there are robust data showing that HPV vaccines are safe. Like all other vaccines, CDC and FDA continue to monitor and evaluate the safety of HPV vaccines. Despite the availability of reassuring safety data, concerns about HPV vaccine safety persist and have been highlighted in the media, resulting in some parents being hesitant to initiate the vaccination series for their children. It is important that clinicians reassure parents who may have concerns about HPV vaccination that there have been over 15 years of safety data for HPV vaccines and that HPV vaccination is safe. Based on our monitoring data showing that HPV vaccines are safe, what type of reactions to HPV vaccines do we expect? We know that we can expect HPV vaccination to cause some injection site reactions such as pain, tenderness, and swelling, and systemic symptoms such as fever, headache, nausea, and muscle or joint pain. On very rare occasions, a person can have a life-threatening allergic reaction such as anaphylaxis to a vaccine, including HPV vaccine. In the United States, anaphylaxis following vaccination has a reported rate of 3 cases per 1 million doses administered. We also know that fainting spells or syncope is very common with adolescents when they receive injections, including vaccination. To reduce the risk of syncope, patients should be seated during vaccination and remain in that position or should lay down for 15 minutes. CDC regularly updates a web page for healthcare professionals with an overview of the research on HPV vaccine safety and effectiveness, including detailed lists of references to assist healthcare professionals when they have conversations with parents about the vaccine. Visit the URL on this slide and share with your staff to ensure everyone is aware of the latest data on the safety and effectiveness of HPV vaccines.
This section focuses on the impact of HPV vaccination. The impact on early outcomes in the orange box, such as HPV prevalence and genital warts, has been demonstrated in just a few years after vaccine introduction. Because of the delay between infection and precancer in the blue box and then cancer in the purple box, it will take longer to see the impact on HPV disease. Post-licensure evaluations are important to assess real-world effectiveness of vaccines. Population impact against early and mid-HPV-associated outcomes has been reported in many countries. In the United States, vaccine impact has been observed on vaccine type prevalence, genital warts, cervical precancers, and juvenile-onset recurrent respiratory papillomatosis. The following slides highlight some of the data. In the United States, dramatic impact of the vaccination program has been observed among females in the National Health and Nutrition Examination Survey, NHANES. In this figure, 4 age groups are examined as shown on the x-axis. The vaccine type prevalence percentage is on the y-axis and shown in different color bars by time period. Among 14 to 19-year-old females, early in the vaccination program, only 4 years in, there was a 56% decrease in vaccine type HPV prevalence in dark blue compared to the pre-vaccine era in gray. Further decreases were seen in later studies from 2011 through 2014 and from 2015 through 2018. In the most recent time period shown in the lightest blue, among 14 to 19-year-old females, there was an 88% decrease in vaccine type HPV prevalence compared with the pre-vaccine era. Among 20 to 24-year-old females, there was an 81% decrease from the pre-vaccine era to the most recent time period. No significant changes were detected among the other age groups. This slide shows vaccine type HPV prevalence from 2013 through 2016, compared with the pre-vaccine era by race ethnicity among 14 to 19-year-old females. You can see that there were roughly comparable and significant declines in vaccine type HPV prevalence among females identifying as non-Hispanic white, non-Hispanic black, and as Mexican American. There is also evidence of a reduction in cervical precancers. These data are from a 5-site population-based monitoring project that collected data on both precancers and cervical cancer screening in the United States. Rates of precancers among screened women have decreased between 2008 and 2015 among both 18 to 20-year-olds, as shown in the solid pink line, and among 21 to 24-year-olds, shown in the solid red line. In 2019, a global systematic review and meta-analysis were published summarizing the population-level impact of HPV vaccination. The review included 65 studies in 14 high-income countries, 23 for HPV infection, 29 for anogenital warts, and 13 for cervical precancers. After about 5 to 8 years of vaccination among girls aged 13 to 19 years, the prevalence of HPV 16 and 18 decreased significantly by 83%, and anogenital wart diagnoses decreased by 67%. Among women aged 20 to 24 years, prevalence of HPV 16 and 18 decreased significantly by 66%, and anogenital wart diagnoses decreased by 54%. There was evidence of herd effects with decreases in anogenital warts among men in countries where they were not part of the vaccination program. This slide shows data from that meta-analysis. The figures demonstrate the difference between decreases in anogenital wart diagnoses among countries that vaccinated multiple cohorts and had high vaccination coverage in blue, and countries that vaccinated a single cohort and/or had low vaccination coverage in red, with the number of years post-vaccination represented on the x-axis. Clearly, vaccinating multiple cohorts and high coverage leads to a quick and significant decrease in anogenital wart diagnoses over time among girls, women, boys, and men. By comparison, vaccinating only a single cohort or low vaccination coverage results in a much slower or no decrease among all groups. These results demonstrate a substantial impact of the HPV vaccination program over 8 years since vaccine introduction, and the value of catch-up vaccination and high vaccination coverage. Returning to some data from the United States, this figure summarizes findings showing declines in juvenile onset recurrent respiratory papillomatosis, or JORP, since introduction of HPV vaccine. JORP is a rare but serious disease caused by HPV that is transmitted at birth to an infant. The number of JORP cases are shown by birth year, the purple bars, with incidence based on either United States national denominator data, the green line, or state-level denominator data, the yellow line. Remember, quadrivalent HPV vaccine was first introduced in 2006, and in 2008-2009, we start to see declines in JORP incidence in the United States. Those declines continue in subsequent years, regardless of which denominator is used. The declines in JORP in the years following HPV vaccine introduction for young women in the United States suggest that declines are most likely due to the HPV vaccination program. These are the first data on declining JORP incidence in the United States. Declines in JORP were also noted in Australia after they introduced HPV vaccine. Although data from clinical trials and post-licensure monitoring have shown effectiveness against HPV infection, genital warts, and precancers, there were no data on HPV vaccine protection against cancer until a study was published at the end of 2020. This Swedish study found a vaccine effectiveness against cervical cancer after introduction of quadrivalent HPV vaccine. Linking population and health registries, the risk of cervical cancer was 88% lower among women who had been vaccinated before the age of 17 years and 53% lower among women who had been vaccinated at the age of 17 to 30 years. Studies suggest that HPV vaccine protection is long-lasting. Available evidence indicates protection for at least 12 years, and there are multiple studies in progress to continue monitoring this. In summary, accumulated data shows that HPV vaccine is safe, effective, and provides lasting protection against the types of HPV that most commonly cause cancer.
This next section focuses on HPV vaccine coverage. This figure shows vaccine coverage for adolescents aged 13 through 17 years from the National Immunization Survey, with the different colors representing different adolescent vaccinations. HPV vaccination is shown in orange and in yellow and green. As you can see, the coverage rates for the first and third dose of HPV vaccines are not nearly as high as the coverage rates for most other vaccines routinely recommended for 11 or 12-year-olds. However, the very important piece of information that this slide provides is that the high coverage rates for Tdap vaccine demonstrates that not only are most preteens and teens going to the doctor, but they are also receiving at least one of the recommended adolescent vaccines. Shown here are coverage data among 13 through 17-year-olds by sex. At least one dose coverage among females shown in blue and males shown in green. Recall that a routine vaccination recommendation was made for females in 2006 and for males in 2011. Coverage increased over time, and in 2020, at least one dose coverage among females reached 77% and among males 73%. Also shown is 3-dose coverage through 2015 and up-to-date coverage from 2016 to 2020. Up-to-date is the measure that has been used since the 2-dose recommendation for persons starting vaccination before age 15 years. In 2020, up-to-date for females was 61% and for males was 56%. So currently in the United States, HPV vaccine series initiation and up-to-date coverage is nearly similar for females and males in this age group. A missed clinical opportunity for HPV vaccination is defined as a healthcare encounter when some but not all ACIP recommended vaccines are given. Had HPV vaccine been administered during healthcare visits when another vaccine was administered, vaccination coverage for at least one dose could have reached 93% by age 13 years for adolescents born in 2006. High HPV vaccination coverage with existing infrastructure and healthcare utilization is possible in the United States. Taking advantage of every healthcare encounter, including acute care visits, to assess every adolescent's vaccination status can help minimize missed opportunities. Potential strategies include using vaccination prompts available through electronic health records or checking local and state immunization information systems to assess vaccination needs at every encounter. Series completion also can be promoted through scheduling appointments for second and third doses before patients leave provider offices after receipt of their first HPV vaccine doses, and with automated reminder recall systems. This slide shows vaccination coverage by urbanicity, and the categories are those living in mostly urban areas, suburban areas, and mostly rural areas. For HPV-1 dose and HPV up-to-date, which are the second to the last and last sections of the graph on the right, among adolescents living in suburban areas, coverage with at least one dose of HPV was 4 percentage points lower compared with adolescents living in mostly urban areas. Looking specifically at the first dose of HPV vaccine, we see that adolescents living in rural areas have always had lower vaccination coverage compared to adolescents living in urban areas. In fact, vaccination coverage in rural areas has always been 10 to 15 percentage points lower than vaccination coverage in urban areas from 2013 to 2020. While both areas have experienced increases in HPV vaccination coverage over time, the increase in rural areas has been roughly at the same rate as the increase in urban areas. Therefore, the difference in coverage between the two groups has been fairly consistent over time. In 2020, the difference in coverage was about 10 percentage points, approximately 78% for mostly urban areas and 68% for mostly rural areas. One factor that may be contributing to the lower vaccination coverage in rural areas is provider recommendation for the HPV vaccine. In the survey, fewer parents living in rural areas reported receiving a provider recommendation for HPV vaccination compared to parents living in urban areas. We know that a provider recommendation is critical to a team receiving the HPV vaccine. As shown in the 2020 National Immunization Survey data, 81% of teens whose parents received a vaccine recommendation from their provider got the vaccine, whereas only 52% of teens who did not receive a provider recommendation received the vaccine. Studies consistently show that a strong recommendation from a provider is the single best predictor of vaccination for any vaccine, including HPV vaccine. In the 2020 National Immunization Survey, 11% of parents who said they would not get their child vaccinated against HPV in the next 12 months identified not receiving a recommendation as one of the top reasons not to vaccinate. In a study from Texas on parents' attitudes about immunizations, parents ranked these vaccines similarly when asked how much value they placed on each of the vaccines. When providers were asked to estimate how much value parents placed on the same vaccines, they guessed correctly for vaccines protecting against meningitis, hepatitis, and pertussis. However, the estimates that clinicians gave for how much value parents placed on influenza and HPV vaccination were much lower. These clinicians underestimated the value parents placed on HPV vaccine. This is evidence of a large disconnect between parents and clinicians. This next section focuses on strategies to improve HPV vaccine coverage and conversations with patients and their parents. Whether a parent's concerns are real or just perceived by the clinician, this affects how they recommend and administer the HPV vaccine. It changes the conversation between the clinician and the parents regarding HPV vaccine. Strong evidence supports the importance of an effective recommendation from a provider. An effective recommendation from you is the main reason parents decide to vaccinate their child. Many moms in focus groups stated that they trust their child's clinician and would get the vaccine for their child as long as they receive a recommendation from the clinician. To make a successful recommendation, group together all the adolescent vaccines and recommend the HPV vaccine series the same way and on the same day you recommend the other adolescent vaccines.
We call this the bundled recommendation because it bundles all the vaccines recommended for preteens into one effective and presumptive statement. The word today is especially important because it conveys to the parent that you are recommending that all these vaccines be given today, not another day. The order of the vaccine-preventable diseases is also important. We want to sandwich HPV between meningococcal and Tdap vaccines. This makes HPV more normalized and gives it the same importance as the other two adolescent vaccines. If HPV vaccine is the last vaccine mentioned, it can seem more of an afterthought, or that you may need to have more of a discussion about it later on. A recommendation could look like this. Now that Sophia is 11, she is due for 3 vaccines. These will help protect her from the infections that can cause meningitis, HPV cancers, and pertussis. We'll give those shots today. Here's another way to make the bundled recommendation, saying a bit more about each of the vaccines being recommended. Now that your child is 11, she is due today for 3 important vaccines. The first is to help prevent an infection that can cause meningitis, which is very rare but potentially deadly. The second is to prevent a very common infection, HPV, that can cause several kinds of cancer. The third is the tetanus booster that also protects against pertussis, so your child doesn't get whooping cough, but also to protect babies too young to be vaccinated. We'll give those shots at the end of the visit. Do you have any questions for me? In this video from the How I Recommend series, Lacey Eden, NP, describes how she recommends HPV vaccine.
When I recommend the HPV vaccine, I bundle it with the other vaccines that are due at that age. So I'll say your child is due for their Tdap, HPV, and meningitis vaccines today. When I normalize those 3 vaccines and make a strong and confident recommendation, I see that most parents are more willing to accept all 3 of those vaccines.
Many parents will accept the bundled recommendation without any questions. Other parents may be interested in vaccinating, yet still have questions for you. A question from parents about HPV vaccine does not mean they are refusing or delaying. Many parents with questions about HPV vaccine are looking for additional reassurance from you. Taking the time to listen to parents' questions helps you save time and give an effective response. Be sure to verify that you are addressing the right concern. Next, we'll give some example questions that parents may ask and some example responses that you can use.
Dr. Rosenblum, why does my child need HPV vaccine?
This question may also sound like, my daughter doesn't really need that vaccine, does she? Regardless of how parents ask that question, we want them to know that HPV vaccine is very important for cancer prevention. You can respond to them by saying, HPV vaccination is important because it prevents cancer. That's why I'm recommending that your child start the HPV vaccine series today.
Doctor, what cancers are caused by HPV infection?
CDC research with parents has shown that many parents aren't aware of all the cancers that can be caused by persistent HPV infection. So some parents may ask you about the cancers that are caused by HPV infection. You can tell parents that persistent HPV infection can cause cancer of the cervix, vagina, and vulva in females, cancer of the penis in males, and cancers of the anus and throat in both. We can help prevent infection with the HPV types that cause these cancers by starting the HPV vaccine series today.
Doctor, is my child really at risk for HPV infection?
It's hard for parents to see their 11 or 12-year-old as being at risk for HPV infection, and they may ask about that risk. Focus on how common HPV is and how they can protect their child from cancer by saying something like, HPV is a very common virus that infects both women and men. We can help protect your child from the cancers and diseases caused by the virus by starting HPV vaccination today.
Doctor, why do we need to give HPV vaccine at 11 or 12 years old?
Asking why now or why at 11 or 12 is another way that parents may say that they think their child is too young for that kind of behavior. In other words, sexual activity. Help parents understand the importance of vaccination before exposure and that we don't wait for exposure to occur or guess when it will occur before vaccinating. Most people are familiar with and endorse the use of bicycle helmets. You could also use seatbelts as an example. Ask parents, when do you want your child to put on their bike helmets? Make the point that we can't guess when the bike accident risk may occur, so we always have our children put on their helmets before getting on their bikes. Data show that most clinicians wait too long to make a strong recommendation for HPV vaccine. This figure shows the strength of HPV vaccine recommendations among those who are pediatricians, represented by PED, and family practitioners, or FP, by age group. A larger percentage of physicians made a strong recommendation for HPV vaccination for older adolescents, represented by more blue in those bars, compared with adolescents in the 11 to 12 years old age group. For each age group, a larger percentage of pediatricians and family practitioners made a strong recommendation. In the How I Recommend video series, Dr. Savoy shares how she answers the question on why vaccination is recommended at age 11 or 12.
For me, this is the moment where I actually start asking questions. And so you sort of pause for a moment and you ask the parent, so tell me more about that. So I'm hearing you saying that you don't want to give the vaccine. Is there something in particular that is making you think he doesn't need it? Or, why do you think your child doesn't need it? And let them explain sort of more about where they're coming from and what their position is. And then it really helps me to answer their questions or to figure out where I might be able to help redirect them to understand a little bit differently where I'm coming from. The most common one I've heard is, my kid's not sexually active yet, or they're not thinking about sex. And my answer to that is, oh my gosh, that's fantastic. They sort of look at me a little bit strange because they're like, why are you excited about that? And you're like, well, I'm excited about it because vaccines are something that you want to give before something happens. And so the fact that they haven't started having sex is perfect because it means that we have time to get in both doses of the HPV vaccine before they're ever exposed, which means it's that much more likely that it's going to protect them against cancer. And for most parents, that's enough to sort of flip the switch a little bit and change their mind.
Dr. Wody, I'm just worried that my child will perceive this as a green light to have sex.
Parents continue to bring concerns about sexual disinhibition following HPV vaccination. You can reassure these parents by saying, numerous research studies have shown that getting the HPV vaccine does not make kids more likely to be sexually active or start having sex at a younger age. Starting the HPV series today will give your child the best protection possible for the future.
Doctor, how long can we wait and still give just 2 doses?
The 2-dose recommendation may cause some parents to think that they can wait another year or 3. You can tell those parents the 2-dose schedule is recommended if the series is started before the 15th birthday. However, I don't recommend waiting to give this cancer-preventing vaccine. Older teens have busier schedules and it becomes more difficult to schedule an appointment. It is best to start the series today so your child is protected as soon as possible.
Doctor, I'm concerned about the safety of the vaccine. I read online that HPV vaccine isn't safe. Do you really know if it's safe?
Naturally, some parents will have questions about HPV vaccine safety. You can reassure them that besides showing very good safety profile during the clinical trial, with more than 15 years of use in the United States and over 135 million doses distributed in the United States, we know HPV vaccines are very safe. Over 100 countries have introduced HPV vaccination.
In this video, Dr. Fu talks about how she recommends HPV vaccine and how she addresses the safety question.
I ask them what their specific concerns are, and I say, wow, that is really frightening. If I were to read something like that, I think I would be a little bit hesitant about the vaccine too. Can we pause just for a minute and let me tell you about what I know about the vaccine. It has been given to millions of people in the United States. It's been licensed in the United States for over a decade, and I am so confident in the safety of the HPV vaccine that I will be giving it to my own son when he turns 11 years old next year.
In this video, Dr. Kassler shares how she addresses safety concerns.
When parents raise questions about vaccine safety, I ask them specifically what they've heard, because often they've heard or read one thing that I can address directly, and I explain to them where there are mistaken bits of information and how sometimes people draw conclusions that one thing caused another when they really didn't have anything to do with each other. The other thing is, I do like to talk about how vaccines are determined to be safe, and I think it's important for us as physicians and healthcare providers to understand how vaccines are vetted for safety before they're even licensed or approved by the FDA, so that we can literally address those concerns with families and parents from a standpoint of knowledge and understanding the science and the system. Sometimes I even talk about the rotavirus vaccine, which post-marketing revealed that there were issues and that vaccine was withdrawn from the market in less than a year. With the HPV vaccine in particular, we've given over 150 million doses, and truthfully, except for perhaps an allergic reaction, the most serious side effect that's been identified is that some teenagers, Valsalva, hold their breath and faint after they have a vaccine. When you put it into perspective for families and explain the facts, many times you can dispel those safety concerns.
Doctor, can HPV vaccine cause future fertility problems?
Sometimes vaccine safety questions can be specific. If you get a question about fertility concerns, you can say, there is no evidence to suggest that getting HPV vaccine will have an effect on future fertility. However, women who develop an HPV pre-cancer or cancer might need treatment that could limit their ability to have children. Starting the HPV vaccine series today could prevent that from happening and protecting your daughter's ability to bear children.
Doctor, why should I get my child the HPV vaccine if it's not required by the school?
Sometimes, parents may request that they only want the vaccines needed for school. It is important to explain the difference between a recommendation that you are making for the health of your child versus a legislative decision that is designed to keep kids who may have missed a vaccination for a highly contagious disease from slipping through the cracks. When you let parents know that you, along with the CDC and the major medical societies, recommend all the vaccines equally for their child's health, you can help them understand that HPV vaccination is a normal part of adolescent health. You can share with them that school entry requirements don't always reflect the current recommendations for their child's health and often focus on prevention of highly contagious diseases. Doctor, would you give HPV vaccine to your kids?
Occasionally, parents will ask you or another person in your medical office if you or they would give HPV vaccine to you or their kids. If you have vaccinated your child, you can share that with parents by saying something to the effect of, yes, I have given HPV vaccine to my child. I strongly believe this cancer-preventing vaccine is very important. Also, the American Academy of Pediatrics, the American Academy of Family Physicians, NIH Cancer Centers, and CDC agree that HPV vaccination is very important for your child. Parents might ask when they need to come back. A recent study highlighted the need for parents to be told when they need to bring their child in for the remaining doses. Most parents do not know how many shots are in the series or what the intervals are. If their child is younger than 15, tell parents, since your child is younger than 15, she will need one more dose in 6 months to a year. When you check out, please make an appointment for the second shot and put that appointment on your calendar before you leave today. For parents of children 15 or older, you can tell them, your child will need 2 more doses, a second one in 1 to 2 months, and a third shot will be due in 6 months from today. When you check out, please make an appointment for about 6 weeks from now and another one for 6 months from now, and put those appointments on your calendar before you leave today. A few parents will be hesitant. Listen to and respond to parents' questions. Sometimes parents simply want your answers to their questions. Your willingness to listen to parents' concerns will play a major role in building trust in you and your recommendation. If you encounter questions you do not know the answer to or information from sources you are unfamiliar with, it is best to acknowledge the parent's concerns and share what you do know. Some parents will not accept your recommendation for their child this year, but that doesn't always mean they won't ever have their child protected with HPV vaccine. End the conversation with at least one action you both agree on. Refusal today may not be final. Revisit the conversation at the next opportunity, for example, at the following annual visit. Because waiting to vaccinate is the risky choice, many pediatricians ask the parent to sign a declination form.
Should I get the vaccine if I am between the ages of 27 and 45 years?
In 2018, FDA expanded the age range for HPV vaccination from 9 to 26 to 9 to 45 years of age. Some adults may ask if they should get the vaccine if they're between the ages of 27 and 45 years old. CDC does not recommend HPV vaccination for all adults in this age group, but rather recommends adults discuss their situation with their doctor to determine whether they might benefit from vaccination. You can respond by explaining, Most sexually active adults have already been exposed to HPV, although not necessarily to all the HPV types targeted by vaccination. At any age, having a new sex partner is a risk factor for getting a new HPV infection. People who are already in a long-term, mutually monogamous relationship are not likely to get a new HPV infection. HPV vaccination prevents new HPV infections, but does not treat existing infections or diseases.
This final section highlights resources available online for healthcare providers. CDC has a variety of resources available to assist clinicians in communicating about HPV vaccine and improving practice to increase vaccination rates. Visit cdc.gov/HPV and click on the section for clinicians. As mentioned, CDC's How I Recommend video series features other practicing healthcare professionals sharing how they make effective recommendations for vaccines, answer patients' questions, and foster a culture of immunization in their practice. These videos feature healthcare professionals from a variety of specialties and cover common questions about vaccines for people of all ages. Visit the URL on this slide to see the videos. In CDC's latest video series, Can I Ask You a Question? Real pediatricians use their expertise to answer parents' questions about the HPV vaccine and why it's important for preventing cancer. The videos feature pediatricians Dr. Amy Levine and Dr. Jose Rodriguez as they answer common questions about vaccines from friends and family. They address questions such as why do boys need HPV vaccine and what diseases are caused by HPV, while going about their routine outside the office, just like many healthcare professionals do throughout the day. Visit the URL on this slide to see the videos. Make sure that all clinic staff, including those answering the phone and making appointments, are communicating the same way about HPV vaccine. Put the focus on cancer prevention and provide talking points for the staff. One way to be sure that staff have the information that they need is to share with them the handout talking to parents about vaccines. Keep all staff up to date on recommendations and best practices. CDC provides multiple education products which are available for free through the CDC website, including immunization courses, webcasts and online self-study, webinars, and You Call the Shot self-study modules. Continuing education is available for this product. As a provider, you can evaluate your vaccination workflow to reduce missed opportunities to vaccinate and thus ensure that all patients are protected. If you are a VFC provider, ask your health department for and attend the next immunization quality improvement for providers called IQIP site visit. The IQIP process provides a review of your vaccination workflow and your vaccination rates, followed by discussions of key strategies to identify areas of improvement, address any gaps, and improve vaccine uptake. Over the next 12 months, your health department's IQIP consultant will check in with you periodically to monitor progress, answer your questions, and provide technical assistance. If an IQIP visit won't be happening soon, have data pulled from your immunization information system or electronic health record for all your 13-year-old patients to assess your vaccination rates and monitor those rates for improvement at regular intervals. These are the references for this presentation. . HPV vaccine is cancer prevention, and you are the key.